Good morning. I'm Dr. Jahan Kim, Assistant Professor of Urology, specializing in pelvic medicine and reconstructive surgery. Today we're going to be discussing state-of-the-art management of overactive bladder and urge urinary incontinence. If you have any questions, please use the UCLAMDChat on Twitter. Today's learning objectives would be to first define overactive bladder and urge incontinence in terms of symptoms and prevalence, learn how to diagnose it, and spend some time learning about the different management options for overactive bladder and incontinence. So what is overactive bladder? Overactive bladder is a clinical diagnosis that is characterized by the presence of bothersome urinary symptoms. There are 4 symptoms to consider. 1 is urgency, 2nd is frequency, 3rd is nocturia, and 4th is urge incontinence. Urgency is defined as sudden, compelling desire to void that is difficult to defer. Frequency is defined as urination of greater than 8 times in 24 hours. Nocturia is interruption of sleep to urinate more than twice. And urge incontinence is involuntary loss of urine that is precipitated by urge. If you have any one of these symptoms, you may be having overactive bladder syndrome. How prevalent is overactive bladder? Well, out of 200 million adult U.S. population, it is estimated that about 33 million of us have overactive bladder symptoms. That's nearly 17% of the U.S. population. If you look at the data in a different format, the prevalence of overactive bladder by age and sex shows that, as you can see, as you get older, the prevalence increases to nearly about 40%. So in summary, overactive bladder can affect about 7 to 27% of men and 9 to 43% of women. There's no difference between North American and other populations. Urge incontinence is more common in women, and as we can see, it is more severe and increases in prevalence with age. What's also important to know is that it has a huge impact on psychosocial function and quality of life. Not only does it interfere with daily activities, but it can have significant negative impact on sexual function and marital satisfaction. It is also linked with depression and anxiety. And as you can see, if you're getting up more than twice at night to urinate, the lack of sleep can impact work performance and has a financial burden just due to management alone. This one study looked at cost of urinary incontinence, and it is estimated that about $3,600 is spent annually by people greater than the age of 65 due to incontinence. So how is overactive bladder diagnosed? Well, it begins with a simple screening question. Do you have bladder problems that are either troublesome or do you ever leak urine? And if the answer is yes, you should ask the doctor to evaluate you and establish a diagnosis. It's important to realize that overactive bladder is a hidden condition. Although it's common among women and men and increases with age, most patients wait about 3 years before talking to their doctor about it. And it can be due to many reasons. Many patients self-manage, and a lot of patients believe that there are no treatments available. And sadly, they're embarrassed to talk about it with their friends and family. So what the doctor needs to know to diagnose overactive bladder is to simply ask a very detailed patient history, review the voiding patterns and symptoms using a 3-day voiding diary, review the medications, do a physical exam, and perform simple office laboratory tests. So here's a busy slide, but it's important to review the different components of urinary history. First is a voiding pattern. It is important to establish the frequency, the timing, and the number of continence voids and incontinence episodes daily. We also have to talk about precipitants of incontinence. Some people have urge and some people have stress. What we're talking about today is an overactive bladder, which is different from stress incontinence that occurs with coughing and sneezing. We also have to take a careful fluid intake history, because if you drink a lot of water, naturally you're going to void a lot. This is not overactive bladder. However, if you're drinking a lot of caffeinated and alcoholic beverages, that can also cause overactive bladder. It is also important to ask about previous surgery, such as vaginal reconstruction and other types of cancer surgery. History of prolapse is important, and it's, we can't talk about it in detail today, but prolapse is when a bladder is out of position of the pelvis and could cause overactive bladder symptoms. We also need to ask about alterations, bowel habits, and sexual function, because it comes into play when we talk about management of these symptoms. Neurologic history is very important because, as you can see, many of us have back pain or even back surgery that can impact the neurologic function of the bladder. History of stroke, multiple sclerosis, Parkinson's disease, and any history of numbness or weakness can signal problems with the nerve system. And furthermore, knowing about the obstetric and gynecologic history, including history of pelvic cancer and radiation, is very important. And finally, we also have to ask about degree of bother. Many patients get up twice a night, but it doesn't bother them. Therefore, it's not, the patient may not need any treatment for a problem that does not bother them very much. So this is an important aspect of the urinary history. Advance the slide. So these are a list of medications that may influence bladder function. And it's a quite extensive list, and these are medications that are used very commonly. So please realize that you have to go over all these medications with your physician, because that can impact your bladder function. On a physical exam, as we mentioned, we evaluate the prolapse by doing a pelvic exam. We look for vaginal atrophy. We have a patient cough and stress and see if there's any leakage. We also evaluate the integrity of the pelvic musculature. Furthermore, we talked about neurologic symptoms, gait disturbances, abnormal speech pattern. We also look for lower extremity edema or swelling, which can impact nighttime urination. And importantly, we have to assess cognitive function, because if you have altered mental status, it can impact your access to the toilet. These are simple laboratory tests that are performed. We begin with a urinalysis. It could start with a dipstick. And what we're doing is we're ruling out blood in the urine, which could signal kidney problems, and also urinary tract infections. Having infected urine can actually increase frequency and urgency, and therefore needs to be ruled out. We also check for a post-void residual urine. It is important to rule out obstructive symptoms, because men with large prostates may have symptoms of frequency urgency, but can also have large post-void residual urine, and it requires a complete different algorithm of management. Here are some of the other specialized testing that we perform. Please understand that these are not initial tests, but can be performed in complex symptoms or patients with other coexisting conditions, such as urodynamics, cystoscopy, imaging studies. So how is overactive bladder treated? It's divided into first-line treatment and second-line treatment for refractory conditions. So let's go over these in detail. First-line treatment options consist of behavioral therapy, medication, and/or combined therapy. It begins with patient education. We need to realize that we understand what a normal and abnormal bladder function is. A normal fluid intake should be less than 4 glasses per day. That equals about 32 ounces in one day. So if you're drinking a lot of fluid, that may increase your frequency, but does not mean that you necessarily have overactive bladder. For patients who void very frequently at nighttime, we advise them to not drink fluid after dinner. Furthermore, we need to eliminate all irritants of the bladder, including alcohol, caffeine, and nicotine. Furthermore, we also educate patients about modifying voiding habits. Furthermore, time voiding, bladder training, and delayed voiding. Also, pelvic floor muscle training is important, as well as weight loss. Some of the behavioral modification program can be teaching the patients to control urgency and frequency by not rushing to the bathroom. Sometimes when you have the urge to urinate, you could concentrate on suppressing the urge, contract the pelvic muscles quickly several times, and it often subsides the urge to urinate. And then you could walk to the bathroom at a normal pace. By doing so, you could have better control of your bladder and have less leakage episodes. Pelvic floor muscle training simply increases the tone and the muscle of the pelvic floor, and thereby improving bladder stability. It has been shown to suppress the voiding reflex. And so by doing so, you're able to suppress the urge to urinate and gain more time to make it to the bathroom on time. For those patients who have difficulty isolating the muscles, we send them to a pelvic floor physical therapist who is able to work with them and teach biofeedback. One study showed that weight loss of about 8% can result in significant reduction of urge incontinence episodes. It showed that in weight loss group, there were 42% who had reduction of leakage and overactive bladder symptoms, compared to only 26% in the control group. So this is something I definitely talk to patients about. Now, if behavioral therapy does not work, we also consider pharmacologic treatment. It is divided into 5 different categories. One of them, probably the most commonly used, is a category of antimuscarinics or anticholinergics. In the US, there are 6 that are approved by the FDA. Darafenicin, oxybutynin, solifenacin, tolterodine, trospium, and fesoterodine. These are name of their pharmacologic compounds. They all have similar efficacy of 70 to 75% for decreasing urinary incontinence episodes. Some of the side effects are dry mouth, constipation, blurry vision, stomach upset, and impaired cognitive function. Although these are not common, they can be pretty bothersome enough to stop the use of the medication. The contraindications for using this medication are those patients with narrow angle glaucoma or those with impaired gastric emptying and urinary retention. Second class of medication that we use can be a type of antidepressant. Probably the most commonly used one in the US is imipramine, which is a tricyclic antidepressant. It causes direct relaxation of the bladder muscle, thereby increasing its storage capacity and allowing it to hold more urine and decrease the frequency. It's also used for childhood bedwetting, so we know it's a very safe medication. It can also improve bladder neck function. Some of the side effects are sedation, dizziness, and nausea, vomiting, so it's typically given at nighttime. The contraindication is for patients who are taking MAO inhibitors. Beta-3 adrenergic agonist is a newer type of medication that was just approved by the FDA. The side effects are high blood pressure, nasopharyngitis, urinary tract infection, and dry mouth, as well as headaches. Because it can cause or elevate high blood pressure, it is contraindicated in patients with uncontrolled high blood pressure. So how effective is behavioral therapy and medical therapy, which is our first-line treatment for overactive bladder? Well, it can reduce incontinence episodes after 8 weeks. Studies have shown that when you use behavioral therapy alone, without medication, the improvement is only 57%. However, when you add the medical therapy, it can increase up to 88%. Taken also from the other perspective, if you just use a drug alone, there's a 72% improvement, whereas if you add the behavioral therapy component, it can be as great as 84%. So clearly, using a combination of behavioral modification and medication can significantly improve your overactive bladder. So what about those patients who do not respond to first-line treatment of behavioral therapy and medication therapy? If the first-line treatment fails, we have 2 options available. First option, it would be the minimally invasive procedures, which include Botox injection to the bladder, percutaneous tibial nerve stimulation and sacral neuromodulation. And if these approaches fail, we can have more of an invasive surgery, such as bladder augmentation, urinary diversion, and pelvic floor reconstruction. Botulinum A toxin, or commonly known as Botox, works by denervating the bladder muscle and decreasing its contractility. The success rate can be as much as 60 to 90%. It can be done in the office with local anesthetic. However, it lasts only about 5 to 12 months and oftentimes must be repeated. And it can be quite costly. Although it was recently approved to be covered by Medicare, a lot of insurance companies were not covered for it. Therefore, it can cost up to $600 to $1,200 per treatment. Some of the side effects would be that it could cause urinary retention, requiring intermittent catheterization. This occurs in about 5 to 40% of patients, so it must be discussed with a patient before we continue. And also, patients can also have infections as high as 20 to 40%. This is a slide showing the technique of Botox injection. This is a picture showing the bladder. We give 20 injections into the bladder, and it could be done in the office. Patient could go home the same day, and patients usually notice improvement immediately. The outcomes of Botox, as you can see in one study, show that there was at least 50% reduction in weekly incontinence episodes, and this lasted up to 9 months. Second, minimally invasive treatment for those patients who fail medical therapy would be a tibial nerve stimulation. It is an office procedure that is performed by placing an acupuncture needle or a patch in the inner part of your ankle. This is then connected to, by a wire to a device that gives electrical impulses from the ankle to the sacral nerves. The typical protocol is about 12 weekly sessions of 30 minutes. If the patient responds, the treatment can be continued at home by purchasing a simple device. And the success rate is about 44 to 80%. But it is important to realize that once you stop these treatments, the efficacy also goes away. The third option is sacral neuromodulation. This is a device that was FDA approved in 1997, and it's manufactured by Medtronic, which also makes cardiac pacemakers. It works by stimulating the sacral nerves to the bladder and modulating the reflexes that influence the bladder, sphincter, and pelvic floor. It's typically done in 2 stages, under light sedation and local anesthesia. The first stage involves placement of the electrodes, followed by about 1 to 2 week trial period using a temporary device. If there is greater than 50% improvement, we move on to the second stage, where the actual permanent pacemaker is implanted, as you can see here, just near the bladder nerves. Here is the anatomy of the sacrum. As you can see, this is a picture of the tailbone showing the 3 different sets of sacral foramen. And this is a picture of the patient showing where the needle would go. Sacrum has 5 different sets of nerves: sacral nerve 1, 2, 3, 4, and 5. The nerves that affect the bladder is actually in the 3rd sacrum. As you can see, we have outlined both in the bone and on the patient's skin side. So after giving local numbing medication, we place the electrode in the area of the sacral nerve 3. And this is done using radiography as our guidance. After we have confirmation with both motor and radiologic, we then place the electrode through the introducer sheath. And as you can see here, it is placed just inside the sacrum. And if there is greater than 50% improvement or reduction in the symptoms, we proceed to stage 2, where the electrodes are removed and we implant a permanent pacemaker. Both first and second stage procedures last about half an hour. patients go home the same day, and there's very minimal pain. It's important to realize for those who are interested in this procedure that you must have good cognitive function, because we have to learn how to use a device, and that requires for you to understand how to use it and understand the sensation with this. But it works quite well. So what are the results? Overactive bladder patients have greater than 70% improvement or partial success. And this is durable beyond the 1 to 2 or 3 year mark. But you must realize that it is a battery and it must be replaced every 3 to 5 years. But it is very easy to change with a simple office-based procedure. It is also important to realize that MRI cannot be performed after this procedure because of the metal component in your body. Some of the side effects experienced by patients could be wound infection, and about 3 to 16% of patients need revision. Contraindications for this procedure, as we talked about, would be need for continued MRI, or those patients with unstable neurogenic conditions such as multiple sclerosis. Certain types of cardiac pacemaker may not be suitable or compatible with this device, and the lack of cognitive function, as we discussed earlier. So what if these minimally invasive procedures don't work? Then what options do we have? Well, the surgical options for severe overactive bladder incontinence include bladder augmentation, urinary diversion, and pelvic floor reconstruction. The bladder augmentation is simply a surgery where you increase the capacity of the bladder. It decreases overactive bladder symptoms by physically increasing bladder capacity. It creates a low-pressure reservoir by adding detubularized intestinal segments to the bladder. And some of the segments we have used are small intestine, colon, and stomach. The contraindications for this procedure would be any patients who have Crohn's disease, which can affect small intestine and as well as large colon, patients who have had radiated intestines, patients with decreased manual dexterity, and those patients with chronic kidney disease because it can alter the metabolic urine symptoms. Here's a picture of the bladder augmentation. You can see intestinal segments which has been detubularized and made into a patch, which is then sewn on to the bladder to increase the capacity. Can we go back? Sorry. So bladder augmentation is done less often compared to 10 years ago, simply because there have been many minimally invasive procedures which have been very successful. It can also be done using a robot instrument in minimally invasive fashion in some places like UCLA, where we have trained surgeons. The hospital stays about 3 to 7 days. Some of the complications can be urinary retention in about 40%, metabolic disturbances, as we talked about, mucus accumulation, stones that could form in the bladder, perforation, and sometimes, very rarely, there can be cancer that is found in the augmented portion of the bladder. Other surgical options include continent catheterizable stoma, ileal conduit, permanent suprapubic tube or indwelling catheter, and pelvic floor reconstruction. These are very rarely used, and it's beyond the scope of today's discussion. But I'll be more than happy to take questions about it. So there are some novel treatment research for overactive bladder. At UCLA, we have an ongoing trial with acupuncture therapy. There's also a very active lab looking at stem cell tissue engineering to increase bladder capacity by building a new bladder using stem cell. This is not available for patients right now. It's right now being used only for animal studies. So in summary, overactive bladder and urgent incontinence are increasingly common in the aging population. Diagnosis of overactive bladder can be made with office consultation without invasive tests. We know that there are various treatment options available. And here at UCLA, in the Division of Pelvic Medicine and Reconstructive Surgery, we offer state-of-the-art therapy tailored to the individual patient to maximize success and improve quality of life. It is also important to realize that there is active research efforts in novel treatment options. Thank you. I will take questions now. So, the first question is, I would like to know what can be done about this condition without having to resort to surgery. We discussed several options. I think that it depends on how much these symptoms bother you and how severe the symptoms are. I would first start by taking an important history from you regarding your fluid intake and how often you're leaking, and discuss fluid management. And if this does not work, we could also add one of the many medications that we discussed. If the medications do not work, we can then talk about the 3 minimally invasive procedures, some office-based and some requiring outpatient procedures. The second question is, what can you tell me about the nerve stimulation for an overactive bladder via an acupuncture needle and electrical impulse? I think you're referring to the tibial nerve stimulation that we discussed before. Can we go to that slide? So it is an office-based procedure where a simple patch is placed in the inside of your ankle. And we connect the cables to a box that you see here. And for about half an hour, they give very gentle electrical stimulation through the ankle. And what happens is the nerves then travel up through the leg and connect to the sacral nerves that control the bladder. It's done for about half an hour, and many of my patients have found it to be very helpful. If that is the case, we can do that for you, but you have to realize you have to maintain it in a home maintenance program using your own device. The third question is, can you explain more about research UCLA is doing for overactive bladder? We kind of touched on this. We have a clinical trial looking at acupuncture itself for overactive bladder, and some of our patients have found it to be helpful. The other opportunity would be to do a special type of neuromodulation and or bladder augmentation. Right now, stem cells are being looked at for animal models, but it is not quite ready for human trials. Next question. If I need to control overactive bladder for an event tomorrow, should I take the oxybutynin today? This is a difficult question to answer because usually we give a trial about 4 to 6 weeks with any kind of medication to see an improvement. Having said that, some patients notice improvement almost immediately. So, you can take it, but it's best to start taking the treatments a few weeks beforehand. Another question, is there a link between overactive bladder and menopause? There is absolutely a link. The hormones receptors, especially for women, are found in not only the vaginal area, but in the urinary tract. And we do know that as the levels of hormones decrease, the tissues around the vagina atrophy, as well as some of the tissues involved in the bladder and the urethra. And there has been a link between overactive bladder and menopause. But it's not enough to say that all menopausal women would have an overactive bladder, because there are other pre-existing conditions that come into play. Another question, is there a connection between overactive bladder and diabetes? There is, in the sense that diabetes is a condition that affects the nervous system. So the peripheral nerves that control the bladder can be affected by diabetes and thereby cause urinary frequency, urgency, and sometimes difficulty voiding. So diabetic patients have difficulty emptying the bladder, which then results in incomplete emptying. And so it allows, or rather causes, increase in frequency and urgency. Can children suffer for overactive bladder? The answer is yes, the children can have symptoms of overactive bladder, such as urinary frequency and urgency. But in that category, it is not diagnosed as overactive bladder, but rather maybe a congenital problem or maldevelopment of the bladder itself from birth. Are there foods that are easier on an overactive bladder? We talked about bladder irritants, such as caffeine and alcohol. Caffeine not only causes you to make more urine because it causes a diuretic effect, but it can also cause a bladder to be in spastic mode, which means that bladder is oftentimes wanting to empty and it is urgent, therefore cause overactive bladder. In terms of foods, foods that contain caffeine, and sometimes people say spicy food, can make the bladder more sensitive and thereby decreasing its ability to store urine. What causes overactive bladder? That's a very good question. I don't think there's any clear answer, but there have been theories that it could be a neurogenic, we talked about nerve dysfunction, as well as myogenic, which talks about the muscle or the wall of the bladder itself. I've heard about a pad test for overactive bladder. What is this test? A pad test simply means that you wear a pad and you weigh it before you wear it, and you weigh it after a day of wearing it. And thereby we're capturing how much fluid is leaking into the pad. And by measuring that, we can then determine the severity of your incontinence. What is the difference between wet and dry overactive bladder? Wet overactive bladder simply means that you have incontinence with overactive bladder, whereas dry overactive bladder simply means you have frequency, urgency, and nighttime voiding, but you do not have leakage. Do certain foods worsen overactive bladder? We talked about this already about caffeinated beverages and spicy food. Another question, can overactive bladder be a sign of more serious condition? Absolutely. A lot of my patients come in with frequency, urgency, and when I do a urinalysis and I see blood, I worry about maybe a bladder tumor or a stone that's in the bladder. So this is something that I look into as well. Furthermore, you could also have dangerous infections that could cause overactive bladder. Remember, overactive bladder has signs of frequency, urgency, and nocturia, which can also result from having a bladder tumor. So that's why it's important to talk to your doctor about it to rule out any of these other conditions. Is there a link between overactive bladder and prostate cancer? Not to my knowledge. Another question, what is a Q-tip test of overactive bladder? A Q-tip test is done for patients who have leakage when they cough and sneeze. So that's a stress incontinence, which is different from overactive bladder. It simply means placing a Q-tip inside the urethra, and we ask the patient to push or strain, and we check for the angle change. And that tells me if you have urethral hypermobility, which can cause stress urinary incontinence. Next to last question. Do Kegels help prevent overactive bladder? Kegels fall under the pelvic floor biofeedback therapy. What that does is, as we saw in the earlier slide, by contracting the pelvic floor, you're able to suppress the urge of overactive bladder and can give you more control. Furthermore, just by having better pelvic floor tone, you may be able to prevent leakage episodes as well. And lastly, is there anything I can do to prevent an overactive bladder? I wish I can say that, and if I had an answer to that question, I'd be a millionaire. I think that overactive bladder is just part of the aging process. If you think of a bladder as just a part of your body that ages just like your arm muscles and leg muscles, it is just an aging phenomenon. But I do think that by carefully managing your fluid and having an active lifestyle, and maybe even losing weight, you may be able to have better bladder control. And I think that's it. Thank you for your time.